Hello, everybody that's able to join us today. We are excited to have each of you as we discuss the update to our report on treatment for opioid use disorder. My name is Emily Noodleman, and I'm the Director of Implementation and Outreach at the Foundation for Healthcare Quality. And I primarily support the Bree Collaborative Program and the implementation of our reports. Each year, the Bree Collaborative develops reports on key health topics facing Washingtonians. Our members identify healthcare services with high variation in the way that care is delivered, that are frequently used but do not lead to better care or patient health, or that have patient safety issues or inequities. For most topics, we form a work group of subject matter experts and leaders to develop evidence-based guidelines. The guidelines take into account existing quality improvement programs and the work done by other organizations. Our reports provide guidelines for multiple audiences, such as clinicians, health delivery systems, plans, purchasers, and others to encourage collective action to promote optimal health for Washingtonians. Our reports are geared towards the state of Washington. However, we welcome other states and other users to review and see how they're applicable to their own areas. The Bree Collaborative forms work groups to bring together individuals across the state to engage in providing their expertise to help craft these reports. We greatly appreciate our work group's members' willingness to share their time, knowledge, and expertise with us. And today we look forward to hearing from some of them and sharing the report with you all. We hope by the end of the meeting, you will leave with a greater knowledge of the Bree Collaborative and our new update to the Treatment for Opioid Use Disorder report, and learn more about how we can promote the health of people experiencing opioid use disorder. During the presentation today, we'll provide an overview of this report. You heard me mention, so in 2017, we developed the report, and this year, or past year in 2024 rather, we worked to develop an update and kind of revamp the report. We'll provide some more context to why and what changes were made shortly. You'll hear from individuals representing some different audiences within our healthcare ecosystem on how they are working to implement some of these guidelines in this report and share how you all may be able to do the same. We will then, at the end of the presentations, transition to a Q&A. You will notice at the bottom of your screen, there should be a Q&A box. Please place any questions you have for our speakers there, and we will review and ask them during that time. The webinar is being recorded, and we plan to send out a PDF slide deck of the slides to those who signed up to attend today and a link to the recording. We will also post the recording on the Bree website. We are really excited to welcome our two speakers today, Dr. Charissa Fotinos, who is the State Medicaid and Behavioral Health Medical Director at the Healthcare Authority, and also Dr. Tom Hutch, who is the Medical Director at We Care Daily Clinics. First, we'll start just providing an overview of our report, so I'll pass it to Charissa.
Great, thank you, Emily. Welcome, everybody. Starting with a little bit of background on the issue, as Emily mentioned, this was an update, but we know that among those under 50 years of age, drug overdose is the second leading cause of death in the United States, and that increase has been 12% in 2024, costing about 71,000 lives a year. So substantial problem that unfortunately, since the first time we drafted this report, the mortality and morbidity related to it has continued to increase. So maybe we're seeing a little bit of hope, don't know yet. From 1999 to 2021, opiate-related deaths increased 6 times. And in 2022, over 75% of total overdose deaths involved an opioid. Highly potent synthetic opioids, primarily fentanyl, are now the majority of the drug supply in the vast majority of the state. In Washington state, death rates due to fentanyl have risen over 750% between 2018 and 2022. And in 2022, were almost 90% of all opioid-involved deaths involve fentanyl. Medications for opiate use disorder, including buprenorphine, methadone, and naltrexone, are the most appropriate evidence-based treatment in addition to harm reduction. And I think as it relates to fentanyl, and the report gets into this a little bit more, we know that for the case of fentanyl, buprenorphine, and methadone are more effective in part due to the potency and risks in transitioning and challenges in transitioning people from fentanyl to opiate agonist therapy. Naltrexone can be used, but it is not as effective and hasn't been shown to be in literature reviews of the comparisons. Next slide. So what are some of the differences between the 2012 and 2017 Bree Opiate Use Disorder Report and the 2024 results? Uh, at that point, we were dealing largely with opioid prescriptions and people transitioning to heroin use as sort of the topic area. Now we're dealing primarily with the issue of highly potent fentanyl. Narcan was mentioned in the 2017 report, but it's a much more significant mention anytime we talk about medications for opiate use disorder or engaging with people who are using drugs that naloxone should be in the conversation and should be distributed. Pain management. A lot of folks who were receiving prescription opioids were doing so for pain management. We didn't really focus on pain management in this report, but I think it'd be remiss to not mention that for a lot of people who are using opioids, great many of them also have pain. So I think it's important to keep that in mind. What are some of the reasons people seek out opioids? It's to treat pain, and that pain can be psychic, it can be physical, and so pain remains an important component, though we didn't call it out specifically in the same way. Already mentioned that heroin is the primary opiate that was available that was not prescription in the 2017 report. Now it's fentanyl. Um, Alternate places of service, we talk a lot about initially through the lens of harm reduction of meeting people where they're at. Many people who use drugs have not been treated well by the healthcare system and so are not going to come seek care unless they have to through an emergency department or require hospitalization. So thinking about other ways in which people might engage with services and having the opportunity for them if they choose to engage or start medications for opiate use disorder to have those available to them. We know more about science, we're getting more information about what works, how it works. And so we're continuing to move from the sort of traditional thinking and reflex when someone says, I am using X substance too much, it's messing up my life, and the response is, we'll go to treatment. And that used to be a fairly circumscribed box of outpatient, intensive outpatient, or residential. Now we know it's a lot more complex than that, and every person has to be individually evaluated, their circumstances determined to decide what's the first step in treatment. And as becomes clear in this report, the first step in the treatment for people with opiate use disorder is medication. This report also addresses some of the federal regulation changes that have occurred, specifically around the ability to provide 72 hours of take-home doses for methadone in certain settings, and better clarifying some of the ways in which you can prescribe methadone in settings that are outside of an OTP, and relaxing some of the requirements that the opiate treatment program, OTP, which are allowed to prescribe methadone for the treatment of opioid use disorder, now have the advantage of being able to implement. And again, harm reduction, really an important focus of this. And that's broadly speaking, if people are using drugs and they're not yet ready or feel that they don't have a need to engage in treatment, how do we lessen the risks of their use for those drugs at any particular point in time? Next slide. And this is an updated graphic and really kind of just shows the sort of thinking that people who, not everybody who uses opioids outside of a prescription has an opioid use disorder. With fentanyl, the risk of that is higher than it might have been in the past with heroin. But people who have an opiate use disorder may seek care through traditional access points, whether that's a primary care office, an addiction medicine clinic, um, inpatient care or emergency rooms, or the traditional treatment care system. But they also are often their first point of contact are in non-traditional points of what we are now, providing access in, but didn't used to think that way. Jails, prisons, sheltered, supported housing, street medicine, teams that are doing outreach, EMS, health engagement hubs, syringe service programs, crisis facilities. So really bringing services to people where they are. And as a lot of you who are engaging with clients who are using fentanyl regularly know, they are significantly impaired. It's a challenge for them to manage through the day, much less negotiate a scheduled appointment, get there and be able to sit in the waiting room and then attend through that visit if they've not recently used. So we have to think differently about how we do outreach to and provide care for folks. And then whether that's a traditional or non-traditional access point, how do we provide the care coordination, peer support, and warm handoffs to help people access mental health services, substance use disorder services, primary care, or other health-related social needs such as food and housing. These are not new things that we know that people all need in order to be healthy and supported. But how do we continue to build on better care coordination? We've brought peer supports in. How can we expand those supports? How do we communicate across these very siloed and different systems? We have to continue to build these connections and these back and forth handoffs and relationships because our system is even if you look at negotiating primary care offices, insurance and pharmacies and who's open and who's not, it's a challenge. For folks who have other challenges in their life, we require more support and continue to need to build those out. Next, please. And so this report focused on these different buckets, education, what are the education needs for providers or patients, access, how do we think about access, screening and diagnosis, treatment, recovery support, and coordination. One thing I'll add is we could have gone into a lot more depth about any one of these, and I think the group was really good in conversation to say we need to narrow this down to really these things as they relate to treatment of opiate use disorder. There's a whole lot more we could talk about and should, but it was beyond the scope of this report. Next, please. These are the guideline audiences. You can read them for yourself, but a number of state agencies wanted to think about health plans, providers, facilities, SUD disorder programs, employer purchasers, correctional facilities, and healthcare services, academic training programs and residencies. So thinking about all those different groups as the group met to talk about this guideline update. How will HCA, Healthcare Authority, use this report? On the Medicaid side, a lot of the recommendations in the report are in place. I think that what we will be doing and can do is really making sure that on our employee benefit side for our public employees and school and benefit employees that we're well aligned within our agency so that we're assuring all the recommendations that are made. We follow both on our Medicaid side as well as our public and school employee side. And that's work we always do with the Bree Collaborative, but really assuring that we across our agency are aligning that. I think the other piece is to make sure that we really are either providing support as we can as an agency to the different entities that I listed in the prior slide with technical assistance or information. If we can provide guidance related to any of the elements in the report, we're happy to do so. Next slide. And then how can health plans use the report? I am not a health plan employee, but was asked to step in and go through this next series of slides from the health plan perspective. I'm happy to do that. Some of the things that the group has made recommendations for was really to remove prior authorization requirements for all FDA-approved medications for opiate use disorder, including methadone, buprenorphine, and naltrexone. And this includes a daily dose-based limit of up to 32 milligrams of buprenorphine. It used to be that before fentanyl was the predominant opioid, people could be managed pretty comfortably on 12 to 16 milligrams of buprenorphine. Some folks would need higher amounts. However, there's a lot of not just anecdotal evidence, but now literature support that people using high amounts of fentanyl are really requiring higher doses of buprenorphine to stabilize their craving and their withdrawal symptoms. Up to and including 32 milligrams, and occasionally, rarely, will get asked to approve a higher dose. So that upper limit really is important to meet the needs of people using fentanyl. I think the other thing I would add here is that there are now long-acting formulations of buprenorphine made by a couple different companies, and looking and making those available for people who would most benefit for those. And I think the other thing that isn't explicit here, but we have found at Healthcare Authority on the Medicaid side, is that it may not make cents that you can pencil out, but some people do actually do much better on the mono product as opposed to the combination product. And so really as a health plan looking at what do our members need, how can we expand these, but at a minimum removing prior authorization, making sure that buprenorphine initiation and continuation can be supported through telehealth, making low barrier access to MOUD a strategic priority, as we talked about, you know, alternate points of access or same day access, and then really reimbursing sort of that glue for helping people navigate a really complex system in the terms of peer support specialists, and how do we help do that. I think the other thing I would comment on the prior authorization is in people transitioning from fentanyl, there is not a one best protocol to do that. And so thinking about someone may need 8 milligrams, and I think Dr. Hutch will talk to this in more detail, but just saying you can have 20 pills for this first week in that transition period may not be enough. The dosing is really flexible. They're high doses, multiple films, multiple tabs. So really in that first phase of initiation, for people transitioning from fentanyl to medications for opioid use disorder, really making their a fairly broad allowance for different amounts on different days with and what are seemingly, you know, different doses, because that's really what folks are requiring to be stabilized. Next, please.
Thanks, Charissa.
That's it. Excellent. All
Thank
right.
you. Yeah. We'll pass it to Dr. Tom Hutch to talk more about how clinicians and clinics can use the report.
Thanks, Emily. Thanks, Teresa. So I was asked to think as a clinician, how do I go through the report and what might I want to focus on for how these kinds of things can be implemented in myself as a provider, maybe in providers that I train or work with, or in my own clinic. So I'll try to kind of go through some of those high yield topics with those eyes. I'm the medical director at We Care Daily Clinics. We're an opioid treatment program here in Auburn, Washington, with mobile units in Tacoma and Seattle as well. We're owned by the Muckleshoot Indian tribe, but we're open to everyone, tribal and non-tribal. I'm a clinical instructor with the University of Washington too, and have learners who work with me, and nothing to disclose. Next slide, please. So I'm going to take some source material from the report and think through it as a provider myself, or maybe as a provider who, and I have plenty of colleagues like this, who are at another clinic. They're willing to do this work, but maybe they're less experienced and don't know where to start. And I'm going to try to cover it from some of those perspectives. So, doctors like to think in cases, and these are some real cases that I've seen down here in Auburn. And there's one that happened at a FQHC family medicine office. So I'll go through these and we'll use them to get into some of these quotes from the report. But the report says to universally screen people in primary care at least annually for unhealthy substance use using a validated instrument. And there's plenty of validated instruments or questionnaires, you could think of them as, that have been studied inpatient or outpatient or both, and are found to correlate really well to ruling in or ruling out somebody for a disease that you need to look further into. So we'll talk about some of them in the next slide, but that is generally a great idea, is to screen, because you don't really know who has opioid use disorder, and we might think we do, but the prescription epidemic, as well as the heroin and the fentanyl wave, have each taught us that people present quite differently, and it really is quite important to screen. So in this case, a 48-year-old came to our clinic here with his partner in 2020, had been getting prescription opioid analgesics from an outside medical provider since 2011, but since 2017 had been buying more pills from another source, not from the pharmacy, and then started using fentanyl 3 months before they came in 2020. That was because his tolerance was really high and he needed to use fentanyl, and otherwise he'd get really very sick, and he went to the emergency room once for that. So the prescriber was not aware that the person essentially, as you can see, had opioid use disorder by now. And this gentleman was asking to switch to buprenorphine. Next slide. So how could we implement this recommendation from Bree? Hey, screen people for OUD. What does that mean and what could that look like? Well, there are some screening tools, like we said. There are many. The Bree report links to them, but there are the 4Ps, the NIDA Quick Screen, the Craft Screen, or the Opioid Risk Tool. The ORT, by the way, is for people specifically who are taking prescriptions for opioid analgesics. So that would have been helpful, perhaps, in this case of this person who was being prescribed pain meds for quite a long time without anyone knowing that he had OUD. I'll also just say as a prescriber, because I am trying to speak from the clinician perspective, sometimes screening programs, especially if you're doing it face to face in the room, can kind of seem intrusive, or it can seem like if I screen this person and they're positive, they might be upset. People know that they have a problem for years before you do as the provider. And it's often, in my experience, a relief for me to bring it up or for them to have the opportunity to talk about it if that screening test is paired closely with a warm handoff and with clarity about the next steps. In my experience, when I uncover something in the primary care world through screening that's a substance use disorder that people didn't bring up themselves, they've generally been very open to talking about it, and it's been on their mind for quite a while. It can be a relief. And so this is a good thing to do from the patient perspective as well. So be aware too, there's other ways to screen. We're talking mostly about patient-reported questionnaires, but urine drug testing can be a form of screening as well. And many people, to go back to our example of this gentleman getting opioid analgesic prescriptions, a lot of offices, if you're in that kind of program, will require drug testing. Be aware that fentanyl is not in most office-based immunoassay or rapid test drug tests. It's just not there. They look for things like morphine or for certain types of pain pills, but fentanyl itself historically is not included in those assays. In the last couple of years, the FDA has approved CLIA waived, which means there's levels of complexity that a lab or an office has to have in order to do a certain kind of test. And a CLIA wave test is one that most MAs and nurses and office personnel are able to do, kind of like a urine pregnancy test. So that didn't exist for fentanyl. There was something called a forensic use only test, which kind of made clinicians think, oh, I'll get in trouble if I use that for medical decision making. So finally, we have one that's CLIA waived, which means that it's fine to use and it's also fine to bill for. So a tip would be if you are worried that someone might be taking fentanyl, maybe because they are part of some high-risk population or they're in some kind of prescription program in your clinic, be sure you're screening for what you're worried for. And these days, fentanyl should be on your radar. So take a look at what you're screening for, and you can add on a CLIA-waived fentanyl test specifically to the same sample, or you can buy new testing panels that include fentanyl. Next slide, please. From the report, speaking of screening, so same general thing, but we're going to switch from OUD to hepatitis C here. From the report, it says screen for common co-occurring concerns, things that happen with people who have OUD, including but not limited to stimulant use. Of course, that's very common in people who use opioids as well, but also hepatitis C virus and STIs. So another real case from a couple of years ago here is a 33-year-old who came in and wanted to stop fentanyl, was asking to start methadone or buprenorphine. She'd been using heroin IV from 2014 till 2020, and then at that point switched to fentanyl. And we ordered some screening tests, HIV, Hep B, Hep C, and syphilis at intake, as we do for all of our new patients. But 2 weeks later, she still hadn't had these drawn. And so we asked her how we can help, and she shared that she tries to avoid needles now that she's trying to be in recovery, and needles remind her of drug use. And also her veins collapse, and they're very hard to stick and get blood from. Next slide, please. So a tip here is, in our clinic, everyone's offered serology. And after that hasn't been done, there is now also, very recently, as you see in this news release from 2024, there is a CLIA waived finger stick test for hepatitis C. Now, you can test for hep C with an antibody, and that'll tell you whether somebody's ever been exposed. But what's very fancy about this new test is that it's a finger stick test for an RNA. RNA means that there's virus in the blood right now, and the person probably needs to be treated. So that's really very useful. If it's positive, the person might still need real blood tests for further investigation before you can safely treat them. But a negative test of this finger stick really helps us a lot reassure a patient, and there's a lot of value in that. And if it's positive, that helps us know who to focus on. If you've got hundreds of patients that still need screening for Hep C, where do you start? You could look at people's risk factors and habits of drug use, but if you know someone's currently positive for RNA, just in the office on the same day test, then if we're going to focus our resources, let's pick this person, let's get them a ride to the lab so they can have an ultrasound guided blood draw or whatever they may need. And so that is what happened with this person. We were able to know on whom to focus, and she started treatment for HCV here with us in clinic. Next slide, please. So moving on to the next main topic of 3, there's options counseling tips I'd like to take a look at. And so in the Bree report, there's a heading called provider education. And so you'll see things like participate in continuing education if you're a provider, and you might be reading the report and say, thanks for the tip, but what does that really mean? And I think I'd like to highlight an example of how important it is to stay up on recent evidence-based guidelines and recent regulations. They may not be the most exciting thing to read, is regulations, but there's a lot of value in knowing what's going on and knowing the recent changes. And I'll try to create a real-world example of a provider that does know some recent changes and how that might affect the well-being of their patients. So become familiar with the latest evidence-based guidelines. In this case, a 35-year-old was hospitalized for opioid use disorder, and it had been an overdose that landed this person in the emergency room. And they had been using sort of differently recently because they were sick. They were found to have pneumonia. And while being hospitalized, they requested to start MOUD for untreated severe fentanyl use disorder, which I will say is a fantastic time to start someone on opioid use disorder. A lot of people, when they come into the hospital, boy, they haven't seen a provider or really had any contact with the healthcare industry for months to years. And now they're here. This represents an opportunity. Maybe they have some newfound motivation to get into recovery because an overdose that landed them in the hospital almost killed them. And now they're looking to, sort of capitalize on this, few days indoors if they're not stably housed. And starting people in the hospital and even just the emergency room has been shown to be quite successful and is really very important to do. So he's talking with the provider in the hospital and says that he's tried buprenorphine 6 times since 2021, but was never able to stop fentanyl, even when taking a high dose of buprenorphine. This was Suboxone specifically. And he just doesn't want to try again. And unfortunately, here on the West Coast in Washington since 2020, this is a common story. It is just very difficult, as Charissa was saying, to get onto buprenorphine in the age of fentanyl. Fentanyl is very strong, it's very potent, it's very lipophilic, it sticks around in the body for a while. And the initial instructions and studies on which the early FDA approval in the early 2000s was based is really not the way and not the doses that people need anymore. And so when Dr. Fotinos talks about how dosing limits, whether it's 32 milligrams a day or whether it's the amount of tabs or films that can be given to someone as an initial prescription, is limiting to their ability to even get started, that is exactly right. We need people to be able to take the amount of medication that works for them, and fentanyl is so much more potent than the medications that this medicine was initially FDA approved to help with. Really does demand that those patients are given enough flexibility when starting. So this gentleman has also avoided starting methadone in the past. He knows that he'd need to go to an opioid treatment program or a methadone clinic. He thinks he'd have to go every single day. he thinks that he'd have to do a lot of counseling and he just doesn't have time for this. He's willing to to start, but he has to travel for his job a lot. He worked in road repair and flagging with the Department of Transportation. So next slide. So how you're the doctor in the hospital, how do you start to answer this? How do you get this person discharged on a medication that is going to save his life? It sounds like there is going to need to be some logistical conversation about what your recovery and what your treatment is going to look like so that it works with your career or your job. There have been some changes in 2024, as you've probably heard. These are the biggest changes really since the 70s in any single rule change. And I'll go over some really briefly here. But it used to be federally that you had to be 18 or above, and there were all kinds of little exemptions that you needed to get if that wasn't the case. Now the federal rule will just defer to the state. And by the way, in Washington, the age of consent for outpatient and inpatient substance use disorder treatment is 13. Every OTP, though, still has their own program policy, and many just do not have the staff training or the personnel or the separate programming set up to take care of adolescents and young adults. But that is changing, and I know of a few OTPs in the state that are looking at that, including ours, and hopefully that'll be helpful in the future. You needed to have evidence of having had opioid use disorder for over a year before even starting methadone. And if you didn't have that, you needed to go through some exemption paperwork with SAMHSA, with the federal government. With fentanyl, because it is so strong and so potent, we are seeing people with moderate or severe opioid use disorder after using for only less than a year. And so this is really helpful. It took away that minimum requirement. In-person exam required at admission. That has now changed, and that admission exam to get somebody started on methadone can now be via telemedicine. The patient still has to be at an OTP to pick up the medicine in the first place, but we find this really helpful doing remote admissions from my clinic here to the patient if they're in their hospital room. Let's say they're discharging straight to a skilled nursing facility, and that skilled nursing facility is only going to be able to continue someone's methadone if they're admitted to an OTP. Well, to do so via telemedicine has right at discharge, that person has a better shot of continuing medication uninterrupted. Max initial dose used to be 30, now it's 50 for the first dose of a new patient of methadone. That can help people move along, and it acknowledges how much of a higher tolerance people have in the age of fentanyl. Counseling, what it has historically regarded as a requirement if you're going to be taking methadone. And the new federal guidelines clarify that attending counseling is not a condition of MOUD treatment. Now, some programs might still require it, or they might still have, some guidelines that they follow internally, but many, including ours, are more flexible on this now if it means that a patient's going to stay with us and stay on treatment. The last but not least is there's been a significant time in treatment limitation since the 1970s. And one example you'll see on the next slide, and that has been relaxed to a huge extent, and it might reassure our patient in the hospital. Next slide, please. I won't go through every one of these numbers, but long story short, you had to be doing well for 3 months before you earned one more take home back in the day. And by the day, I mean the last 50 years. You could do well after 91 days. You could get one more take-home dose. So maybe you come to the clinic Monday to Saturday, and now you only have to come Monday to Friday. As you can see on the right side there, that's been relaxed quite a bit. In the first 2 weeks, you can walk into the OTP and get a maximum of 1 week of medication at a time. And this is methadone, by the way. The time and treatment criteria, if you're getting buprenorphine products at an OTP, was taken away years ago by SAMHSA. So there's no limit really on whether you can get a month of Suboxone at an OTP. For methadone, though, at the rest of that month, you can get 14 days. And after you've been at the OTP for a month, you can get up to a month of take-homes. Now, they're not saying you have to give everyone this amount, but and most programs will be judicious about where is this person in their recovery? Are they safe to have a whole week? We just met them 2 days ago. It's not like this is what everyone defaults to. What has essentially happened is that SAMHSA has given the option back to providers to decide how much. Next slide, please. What you might also want to know as a provider is if this person is going to a skilled nursing facility, or my patient after discharge from the hospital is going to go to an assisted living facility, chronic care hospital, they can actually get methadone dispensed to them right in that facility. So I don't want to get into the specifics anymore here because I'm trying to focus on what can a provider in their counseling to this patient inform them about for what is the most accurate, updated way that people can get medication. But being at an OTP is no longer necessarily the only way that you can get methadone for OUD. And it's important for providers to know about that and maybe to be familiar. Let's say you're a case manager, discharge manager, medical provider, nurse at a hospital, and you've got every month a few people who are hanging around and are difficult to discharge and find placement for because it's got to be a place where they can continue their methadone. Well, now maybe when you speak to these places, you can inform them about this rule so that if that skilled nursing facility or assisted living facility is interested and has a pharmacist, they could just stock methadone and hand it to the patient every day. It's a lot different than only having one or two sniffs and waiting for beds to open there because those are the only ones that will take patients on methadone. Next slide. So, what to tell a medical provider who wants to be sure that when their patient, whether it's here in the hospital for our current case, or whether it's someone who comes into their PCP office and says, "You're right, I should get treated for OUD. What are my options?" There's 3 FDA-approved medications for opioid use disorder: naltrexone, buprenorphine products, and methadone. And in order to help that person decide, let's say that they say, "Well, I've been coming to you for 10 years, doc. I trust you, and whatever you think is what I'm going to choose." In order to have the most informed conversation with them, I think that the logistics are so central to being on methadone for OUD that to do a good job really giving informed consent to a patient, we need to know what the most updated rules are. So you can find some an updated brief. I guess this is 2 pages, if it's pages 14 to 15, on this document called Federal Guidelines for Opioid Treatment Programs, which you can Google. Be sure you're not looking at the 2015 version. This is the one that just came out a couple of months ago that has these new rules in it. And maybe get on the phone with your local friendly OTP and have a talk with somebody in admissions or a dosing nurse or a med provider or the medical director and go over, you know, 5 things. Maybe say, "Listen, I've got some people with OUD, and if one of them asks me, how do I start methadone? What do you think I should counsel them like? What info should I give them? When are you open? Do you need any paperwork from me?" If we can have warm handoffs for these patients, especially because they're usually higher risk patients, these are people with OUD that's so severe that buprenorphine hasn't or won't work with them. We really do deserve to be able to give people warm handoffs like that. So that's a plea to have a couple relationships with OTPs near you and be able to do good counseling when you need to. This is the last topic here and it's about the lowering the buprenorphine barrier. From the report, I won't read all of this, but it's important to see clearly there's a problem in that from 2018 to 2022, 750% is how much fentanyl deaths have risen in Washington. Bup and methadone are very effective, reducing mortality by over 50% and should be offered to any individual interested. And a minority of primary care clinics offer buprenorphine. So there's a bit of a disconnect there, a serious treatment gap that translates into more harm and more mortality and more overdose than may need to happen. So in our 4th case here, a 48-year-old man with no known history of SUD, substance use disorder, screens positive for severe opioid use disorder with 9 months of fentanyl use at his PCP's office. And this is a real call that I got about a patient from my colleague who works in a family medicine office, but that family medicine office doesn't have, quote, a buprenorphine program. The patient has tried on his own lots of times, can't stop, wants some help. And my colleague is saying, I'm willing to help, I want to help, but nobody in my office is on buprenorphine. I'm not sure what the next step here is. Next slide, please. From the report, Bupe can now be prescribed by any licensed provider in the state of Washington, does not require a waiver from the DEA, no special training, although of course you should be educated about everything you're prescribing. There's no extra waiver or anything that you need, and most pharmacies have buprenorphine. So while clinics and patients and providers, I think, would of course benefit most from a well-resourced outpatient program, there are lots of levels of offering Bupe. If you don't work somewhere where everyone is doing it and there's a whole sort of, manual set up, we don't think that that should be a barrier to the patient receiving medicine that day because of how much impact we know just starting the medicine has. Next slide, please. So there's just a few levels. These aren't formal, but set up an OUD outpatient treatment program. Let's say that my colleague on the phone said, well, I've got a lot of people who ask me about this, and I think we should do it right, and I want to know what steps to take. That can seem like a daunting task, starting a program at a clinic, but also, zooming out, this is another condition, and we treat individual conditions all the time without having terribly specific protocols for every single condition that we treat. And you could find the right mix of protocol versus judgment in your clinic, but setting something up is generally preferred, and there are a lot of resources to do it. So right within the report, there are some links, and I highlighted 2 here that you can see under level 1. But some of these resource kits are practically a walkthrough with sample forms and workflows that can be really very helpful in setting that up. The next level, if you don't want to or can't go to that extent, is to educate yourself well, and to prescribe buprenorphine, become a buprenorphine prescriber. And that shouldn't sound daunting either. There's no special ceremony. Of course, there's training, but there should be training before anybody starts prescribing anti-epileptics or antidepressants. There's really nothing more fancy and formal than that. And so even if people are referring elsewhere, it is good for that patient to leave the office with an actual prescription of buprenorphine. Even if you're not going to take care of them long term, this is a big ask, and a big recommendation from this whole group is to just get buprenorphine into their hands. There's no longer a waiver required, there's no counseling required, and we know that there's a serious mortality benefit when taking Bupe, independent of whether they come back or whether they're on it long term. Of course, it's better if they're on it long term, but providing it that first day is hugely important. There are quick start protocols right within the report, like Scala Northwest's clinician resources, tells you the dose, tells you the instructions. It's very doable, and it makes a huge difference. Level 3, you're not able to do it. Well, if they live in King County, they can call this number 24/7 and get a prescription over the phone. Hey, if they're able to do it over the phone, it must not be too hard. But hopefully this expands to elsewhere in the state. But right now, if the person resides in King County, that is an option for them. And if you're not in King County, or your patient rather isn't, then you can kind of set up a similar network like this with other colleagues. In fact, that phone call that I got from this person who's a PCP, um, you know, uh, that person was taking initiative to say, well, I don't really know how to do this yet, but I'm gonna phone a colleague. And if you're listening and you could be that colleague for someone, that can make a big difference. And otherwise, reach out to those around you who know how to do this, and at least try to get that person in for that day, because like I say here on the bottom, the goal really should be the same day prescription rather than the person leaving the office with just a referral, because in really all of addiction treatment, sometimes there are small windows during which someone is ready to accept help, and that window could close, the next morning, because a lot can happen overnight.
Thank you so much, Dr. Hutch. We'll invite Dr. Charissa Fotinos back on, and we'll have a Q&A. So if you have any questions for our speakers, please place them in that Q&A box. We did see a comment came through that, just as a reminder, is And if Tom or Charissa, if you have a comment on this too, is ORT is an older instrument and not intended to screen for OUD, rather intended to risk stratify for COT, which is chronic opioid therapy for pain management, and also just being mindful that it being an older instrument has some stigmatizing language, such as the term abuse. So we just wanted to uplift that. Oh, Charissa, we'll have you come.
Yeah, yeah, we go. Yeah, as I mentioned, Mark, appreciate the call out. It is, I mean, it's hard to find great, perfect tools, but good call out on that one, focusing primarily on use for chronic pain and that it is a bit dated. So
Definitely.
Yeah, I had a question. I think either of you can answer this. Dr. Hutch, when you were presenting, you were on the first case study you were showing, you were talking about I think actually maybe it's second, talking about initiating OUD treatment in the hospital and how that's a really great location to begin treatment. Can you talk a little bit though about transitions of care? I think not just with OUD, I'm seeing this as a theme in healthcare, is it is really hard to you lose people during transition. So hospital to a PCP, do they have a PCP? I was hoping you might be able to speak to how can we strengthen that transition of care, both in your work with King County, but recognizing King County is a county in Washington State that has a lot of resources. So if you feel comfortable also speaking to those outside of our county and other areas of Washington State that may be more rural.
Sure, and I'll err on the side of brevity, or try to, because the specific situation can look a lot different in this really good general topic, which is someone has started on MOUD in the hospital, and how can we ensure that that's continued without interruptions to their care as they are discharged and start care elsewhere. In the case of buprenorphine, it's given from the hospital pharmacy, but as soon as they leave the hospital, they should be able to go to a pharmacy to get a prescription. That first prescription might be able to come from an inpatient prescriber until they're able to get some kind of longer term care. A second option would be a bridge prescription. Maybe if the hospital team reached out to that person's PCP or to a local office-based opioid treatment program that they wanted to have this kind of discharge referral relationship with, that receiving provider could call the pharmacy and call in a week of a Suboxone prescription in anticipation of that person coming in to see them. There are a few ways that could be done, but it's pharmacy centric. For methadone, methadone is started in the hospital, and being a hospital, they can dispense methadone. But in the outpatient world, to dispense methadone, you generally have to be an OTP or one of those sort of long-term care facilities that I highlighted on that recent change. So there are a couple of strategies here. Let's say that a patient goes into the hospital, they're hospitalized for a couple of weeks with a serious infection, and during that time they're stabilized and they leave on methadone. And up until their last day, their methadone dose is getting stable. It's at 120 milligrams, and they're kind of feeling okay, and they're really sold on the idea of continuing the methadone, but they have to go to a skilled nursing facility for continued care straight from the hospital. That skilled nursing facility doesn't have methadone, they don't have a pharmacist, but they're willing to accept the patient. Well, what needs to happen is that person, to continue getting methadone, they need to be enrolled in an OTP. But if they're going straight from the hospital to the skilled nursing facility, when does that happen? Do you just kind of cross your fingers and make an appointment for 8 a.m. at a local OTP on the day that they're leaving the hospital, and drop them off and pick them up again 2 hours later, hoping that everything goes smoothly? That is generally how it's been done, and sometimes things fall through. And as you can imagine, if you show up at the SNF without having had that appointment, then you don't really have a way to get methadone. So you have to arrange for transportation to the OTP. And then, every week, how are you getting medication? Is it being dropped off by the OTP a week at a time for skilled nursing facility staff to give? Or does the skilled nursing facility or adult living facility, assisted living facility, have to drive the person to the OTP? So you can see in the world of methadone as compared to bupe, the logistical concerns are really quite important. and are unfortunately often reasons that people not only discontinue methadone, but might not even start in the first place. There are some things that can help. I talked a bit in the presentation about how we will actually just do a telehealth admission to our program of the patient when they're sitting in the hospital. And there's us and one other OTP I know of that do that at a few of our local hospitals. And so they leave the hospital, now they're admitted to our OTP. As soon as they walk out the door, they're our patient. So it's just a matter of getting medication to them. So maybe they go to the skilled nursing facility straight from the hospital, and we just start dropping off medication to the skilled nursing facility staff for them to store and dispense to the person each day. Another quick thing I'll talk about, boy, I started this answer saying that I would err on the side of brevity, and I'm failing. But this is the last thing, is 21 CFR 130607B, aka the 72-hour rule, is something that the DEA allows just about any practitioner if they have access to methadone that they can dispense. So that means a doctor in a hospital. You can give up to 72 hours worth of that medication to the person for the purposes of helping bridge them to care. So you are the hospitalist. This patient is nearing discharge. They promise on Monday that they're going to go to their local OTP and do a walk-in admission, but it's Saturday at 8 a.m. or it's Friday night, and that's not going to work at the OTP. They can't show up at the OTP on Friday night or on Saturday afternoon to get in for admission. So how are they going to have medication on Saturday and Sunday? And it is a big deal in OUD to not to go a day without medication. That could be the difference between them staying in treatment or going off and using fentanyl and never seeing them again. So anybody can give those 72 hours, 3 bottles of methadone, as an example, to the patient. And there are a couple local hospitals that do that, Swedish and Harborview. And I think that more should. And while there are barriers, and I want to respect hospital policy and personnel time and safety issues, it is not right to say that there are federal regulations that don't allow that to happen. It is possible, and it does make a huge difference for our patients.
Thank you. There's a comment too in the chat that was, or sorry, in the Q&A that was said, has the addition, I believe it is xylazine to fentanyl been discussed in more detail for any of these scenarios?
I can start with that, and maybe Tom, you can add anything I leave out. I think if you look at drug seizures and drug testing across the state, the amount of xylazine in the drug supply here is pretty minimal. It's not like it was, not like, in other settings like Philadelphia, the East Coast, where there was xylazine in a large amount of the fentanyl. I do think, some of some providers have mentioned that they're seeing wounds. There are good guidelines in place now about how to care for wounds. So the ways in which really aggressive care first started for these folks have sort of developed into old school wet to dry dressings. So there are some learnings from other places that have had large amounts of xylazine in the drug supply to manage these chronic wounds. Again, there's not a lot of xylazine throughout the drug supply in Washington. I think points to know are that Narcan alone, if Narcan isn't working after a dose or two, people should not need 7 doses of Narcan. That's a separate discussion. But that the main significant effect of xylazine at the time of an overdose is prolonged respiratory depression, and that won't resolve with naloxone, and that folks may need bag and mask respiration. So I think not as much of an issue as a lot of us were initially worried about. It is out there, but it's not a predominant contaminant of the drug supply here. Tom, I don't know if you want to add anything more to that.
Well said.
One thing, I just wanted to add a comment, Tom, to your mention of the 72-hour rule. Healthcare Authority is working in partnership with the Department of Health, and we'll be having a call with the DEA, the Pharmacy Commission, and the Washington State Hospital Association, really to get it from the DEA that what Tom was talking about, the 72-hour rule, is allowed. It's pretty straightforward. There's a path to do it, and hospitals should not be afraid of their risk in doing so, nor should providers involved in the provision of giving people this 3 days of methadone dispensing to transition them across places, hospital to the SNF or hospital to a methadone treatment program, that those are allowable, doable, and safe ways. So that'll be upcoming.
Charissa, I'm looking at the time. I have one question. I have kind of a two-part question for you. As our Bree chair for the work group this year, what is one thing that you're most proud about in the report? And what is one takeaway from attending today's event or the report that you hope someone has?
I think really appreciated the facilitation of Bree staff. The whole process has been really easy. It's plug and play for those of us who are asked to support this work and offer our time to help inform it. I think the group was very collaborative, worked well together, and was really interested in getting to usable points and information for the different audiences that were a focus of the report. So it was a good experience, well facilitated, and people were really, really at the table to focus on, we have a big problem here that we want to solve collectively, and we know we all have a part to play in that solution. I think listening to this conversation, the thing I kept thinking about is, we have focused, rightfully so, on treatment. The primary linchpin, as it were, is being medications for opioid use disorder. And those are necessary to reduce the risk of death, like Tom said, by 50 to 60%. We don't have anything that's that effective in medicine, period. So medications are the first treatment, and that's to get people stabilized, sort of help rewire their brain circuitry so they can better retain information, and really start to let us know what they need to move down their path of recovery. So I think the medication is the first thing, and I think sort of next iterations of this is, then how do you unpack and support people who likely didn't just use fentanyl because they were bored one day and entered down this pathway of challenges? What are the circumstances and settings in which people were using? What were the reasons in which they used? Trying to understand some of those underlying events, reasons, so that when they are stable and not just focusing on managing craving or withdrawal symptoms, how do we help support them in their path of recovery? What are the behavioral health needs, the trauma needs, whatever other needs they may have? So I think the next piece of that is, okay, now what's next, right? How do we take the next step in supporting folks? And that'd be my response.
Thank you. We also just want to take a moment and share the group. There was a subgroup of this work group that worked with our measurement and evaluation manager, Carrie Nicholas, to really help develop some new evaluation tools to go along with this report. So there is an opioid use disorder treatment evaluation metric, an evaluation framework. There's an opportunity where we call them scorecards within the Bree Collaborative, where you have the opportunity to kind of assess how your work is doing. Let us know. We would love to uplift your work and celebrate. We have an award program too, that we would love to kind of see what your scores are, and also just help you with the implementation to help improve this topic within Washington State. I can see we're putting some information more in the chat, but we'll also follow up on email with these, but you can access it online. We also have a survey for the webinar. If you wouldn't mind filling that out, would be fantastic. And we have a lot of upcoming events, so we hope you continue to join us. Everything you see on your screen is free. It's a webinar, virtual. We will be recorded like this. And so we encourage you to come back and continue to come to these events with us. And lastly, we really just want to extend a gratitude to our work group members like Dr. Hutch and Dr. Fotinos for all of the hard work in developing this report. We want to celebrate Beth Botchkov, our Director of Research and Best Practice at the Foundation, who was helping develop this report and facilitate those work groups. We are just so grateful for everybody to come together and develop this, and that's something that makes this report so special. If you have any questions, comments on the report, please reach out to Bree staff. However, we hope you have a great day, and thank you so much for joining us today.